I'm Dr Srivastava. I'm one of the liver consultants based in Cardiff. I've been there for about 4 years. And I have a very keen interest in PSC. And thanks to Martin and Maxine for the invitation to talk. And thank you all for coming. It's the first PSC support group and the Information Day in Wales. And I think we hope to build up on this and have more regular events at least on an annual basis. So what I'm going to talk to you about is a brief overview of primary sclerosing cholangitis and its management and ongoing care. So it's quite a short time to cover all of that, but please feel free to ask any questions during the talk. I think that's what it's very informal. Okay, so I just thought it'll probably quite good to start with the basics, just so that you understand. And I think a lot of people need to visualize anatomically what's going on with PSC. And this is the liver, which has got tiny bile ducts, or the tubes, which then join to form the main bile duct, which is called the common bile duct. And that opens into the small bowel. And that's the gallbladder joining into the common bile duct. And in PSC, there is inflammation and scarring of the bile ducts right all the way from inside the liver to involving the main bile ducts, including the common bile duct. So it can be quite extensive, or it can be just limited or confined inside the liver. And that is the variation that people have. Some people have a very localized disease and very early disease, whereas some people may have quite extensive disease involving both the bile ducts in the liver and outside the liver. And that is what partly determines how quickly someone progresses. In addition to that, you can see this is the bowel. So there is a very close relationship between the gut and the liver. All the blood flow from the small intestine and the large intestine goes through the liver. So there is a very close network between the gut and the liver, and there is a gut-liver axis, and a lot of research is being currently focused on that aspect. And we do know that people with PSC, there is a very high prevalence of inflammatory bowel disease. So there has to be some common sort of pathological mechanisms, and that is what a lot of research is trying to establish. So what actually is PSC? So it is a chronic liver disease, which is characterized by inflammation and scarring or narrowing of the bile ducts. So that's a normal bile duct, and that is what happens in PSC. Eventually, because of the bile duct narrowing and the scarring, the bile is not able to drain through the liver, and it stays in the liver, which is quite toxic to the liver cells. And that is the bit that causes the scarring of the liver, and that is what leads to what we call as biliary cirrhosis. It's a very complex disease, both for the clinicians and individuals who suffer from it. It is fairly uncommon. I won't say it's rare. I think in the UK, we estimate there are between 5,000 to 10,000 people who have PSC. But it's not everybody is diagnosed. And I think that is the difficult bit. There is a very high prevalence of inflammatory bowel disease, mostly ulcerative colitis and some Crohn's disease as well. And about a quarter of individuals who have PSC also have other autoimmune diseases. And I'll touch a bit more on that. It's the 5th commonest indication for liver transplant in the UK. In Scandinavian countries, PSC is a lot more prevalent. For some reason, the exact reason why it is, it's not clear, but it's the leading indication for transplant in those countries. It is diagnosed on the basis of an abnormal cholangiography. Now, this is usually in the form of an MRCP these days. We don't do ERCPs to diagnose PSC, so most of you probably would have had an MRI scan to diagnose PSC. And in some cases, we do a liver biopsy. Now, in terms of the early PSC diagnosis, that can be quite challenging because a lot of the people don't have any symptoms, and most people in the early stages are often diagnosed purely because they've had a blood test which has come back as abnormal, or they've got another autoimmune condition. Usually that is ulcerative colitis. And in that context, if somebody has an abnormal liver blood test, then people start thinking about PSC, and that's how it's picked up. People don't necessarily present in the early stages, not all of them. There has to be an index of clinical suspicion, and I think Martin alluded to the fact that not all doctors, especially who are not gastroenterologists or liver specialists, would think about PSC necessarily. So it depends who you're seeing, you've come into contact with. But I think one thing I would probably want to mention is what's happened over the last sort of 5 to 10 years is there are a lot of subtypes, and historically, any disease of the bile ducts which look like PSC was being clubbed into PSC. And I think we have realized, I think over the last 10 years more so, that there are distinct phenotypes or subtypes. So you have the classical large duct PSC where you can see the changes on the MRI scan. Then you have people who've only got maybe an abnormal liver blood test, MRI scan is normal, and the PSC changes are only visible on the liver biopsy. So that's the small duct PSC. You have a small cohort of patients who've got PSC, but also features of autoimmune hepatitis on the liver biopsy. And that is normally called as AIH overlap syndrome. And then there is this subtype, which I think has gained a lot of interest in the last 5 to 10 years, 6 years mainly, is the IgG4-related sclerosing cholangitis. I won't go into the details of these conditions, but it's important to be aware, and for your specialist to be aware that, to think about these conditions and make sure that the diagnosis is correct. What do people present with? And I think it's quite interesting that almost a quarter of the individuals who have PSC were completely asymptomatic. They may develop symptoms as the disease progresses, but I think early on, they don't have any symptoms at all. But then people who do have symptoms, they can have a mixture of abdominal pain, itch, fatigue is very common, jaundice, recurrent bouts of cholangitis. So it's a mixture, and all of these symptoms may not necessarily need to be present all the time. I think it's important. Fatigue has come up quite often, and I think it is a debilitating symptom. It does impact on the quality of life quite significantly. We don't fully understand what drives the fatigue. We know there are lots of different factors which probably play a part, and there has been a lot of research, more so in the context of another autoimmune liver condition called primary biliary cholangitis, which is PBC, but the mechanisms are thought to be the same. And there are established sort of changes in the brain and in the nervous system which drive a more central fatigue. And we know that the blood pressure is affected, the cardiac output, the cardiac function is affected, and all of this leads to fatigue, along with other symptoms which may be present like depression or the itch, sleep problems. So the multitude of symptoms and factors that drive the process. And that is the reason why it's difficult to treat with one particular drug, because I think often there are multiple factors involved. But there is an interest in finding new treatment for fatigue, and I think we'll probably have to watch the space in the next few years. So I just wanted to, over the next few slides, give you a bit of an overview of the UK PSC consortium. So this was set up in 2008, 2009 by Graham Alexander. I was one of the first research fellows for the UK PSC study. And if you have taken part, you're probably quite likely that I would have sent you a participant questionnaire or a consent form. And this was to try and develop a national cohort of PSC patients. And mainly to try and describe the clinical characteristics as to what patients with PSC present, what age group they are in, what other diseases they have. And the main sort of underlying purpose was to try and define the genetic risk. That is what the UK PSC study was initially set up for, as Martin has mentioned earlier, and to try and find out if the genetic studies can shed some light on what is abnormal with the pathological pathways, what goes wrong in PSC patients. And so that was the initial setup. And I thought it would be quite interesting because some of you may have taken part in this, and I think it's important for you to look at what we found from all the data that we collected from you, because otherwise this would not have been possible. So to date, I think we've got more than 2,000 individuals with PSC into the UK PSC study. Half of these individuals were recruited from the transplant centres. I think that is important because people in transplant centres usually have quite advanced disease and complex diseases, whereas people who are more in peripheral hospitals, they have a more benign course. I think it's important to have a good mix of both severe and other cohort of patients. We had a detailed participant questionnaire completed by almost 1,200 patients. Of the total cohort of patients, we had about 320 patients who had a liver transplant. A very small number had a second transplant, and 3 individuals had to have a third transplant for recurrent PSC. And this was the sort of demographics. The median age at the time of recruitment was about 58 years. And the age at diagnosis of PSC, so these are the patients where we knew when the PSC was diagnosed, and as you can see, they are fairly young, so in their 40s, and the age range was quite wide. And those who had ulcerative colitis, they were even younger, so they were in their 20s when they had their IBD diagnosed, and then maybe about 10, 15 years later, they had the PSC diagnosis. Predominantly, these were males, and we know that PSC is a male-predominant disease, and the male-female ratio was about 1.7:1. In terms of the inflammatory bowel disease, so it was present in about 66% of our patients. 34% of the cohort just had PSC alone and no bowel disease or no bowel involvement. And those who had inflammatory bowel disease, it was predominantly ulcerative colitis, and a small proportion had Crohn's colitis. I think this is quite sort of useful information as well in terms of other autoimmune diseases. We talk about people having one autoimmune disease being at risk of getting other autoimmune diseases, and this is what came out of the UK PSC participant questionnaires. The blue columns are the sort of the prevalence of autoimmune diseases in those who had PSC, and the red bars are of the general population. So you can see clearly people who have PSC have a higher risk of getting other autoimmune diseases, such as thyroid disease. That could be hypothyroidism or celiac disease or type 1 diabetes. A very small proportion had SLE. So I think the importance of this really is to think about if individuals have other symptoms, then those conditions should be excluded actively.
Sorry, is that percentage out of 100?
That's percentage, yes. So just in summary from the UK PSC data that we had, and this is quite an old data now, but this was the largest reported cohort of PSC individuals worldwide, and we knew that sort of PSC is more prevalent in young, non-smoking males. There is increased prevalence of inflammatory bowel disease and other immune-mediated diseases. And the main questions really was, what causes PSC? Is it an autoimmune disease? Is there something wrong with the immune system? Is there a genetic risk? And I think that is why the genetic study was done. And I don't want to take too much time talking about the genetic risk, but I think because this is what came out of all the DNA samples and the blood samples that we took from you for the PSC, I think it's important that you see what we found in terms of the genetic risks. Very briefly about the PSC and other autoimmune diseases. Okay, so a classical autoimmune disease is predominantly is mainly seen in females. There is a very specific blood test that you can do to diagnose that condition, and there is very good response to immune suppression. In PSC, it's a male-predominant disease. There is no specific blood test that you can do to diagnose it. There's no specific autoantibody that you can check and say, yes, you definitely have PSC. There are some markers which we do check, which probably suggest, yes, that's more likely to be in keeping with PSC, but it's not diagnostic. And we know that in terms of the treatment and response to steroids, in children with sclerosing cholangitis, there is quite good response, whereas in adults, there is no response to treatment. So it's not a classical autoimmune disease. And what we think is it's probably an immune-mediated disease due to some unknown trigger, which is what we need to try and find out. Skip that one. So this was the genome-wide association study that was done with the UK PSC cohort. And what essentially, in summary, what we did was we looked at the genetic makeup of individuals with PSC and compared that with healthy individuals and to find out what the differences were. And you could do that with very complex bioinformatical algorithms. But in a nutshell, that is what the purpose of the genome-wide association study was. And this is what we found. So over the last sort of 7-8 years, a lot of genetic studies have happened in PSC, and these are the different genes that have been associated with PSC. And the 3 big studies where we included the UK PSC data is highlighted in bold. What's happening now is people are taking these genes forward to find how that is altered or how that is modified in people with PSC to try and see if there is anything that can be targeted for treatment purposes. So I think this was the first phase. So I think a lot more research is going to happen looking at taking this forward over the next 10, 15 years. And some of the genes that we found to be associated in PSC were also seen in other autoimmune diseases like celiac disease, type 1 diabetes, SLE, Crohn's disease, rheumatoid arthritis. So there are clearly some common links and common pathways. So I think watch the space, and I think we probably have more research coming out looking at specifically if targeting these genes makes any difference in terms of treatment and the outcomes in PSC. I think this was the summary about the common pathways that link PSC with other immune-mediated diseases. But I think this is probably what's more relevant from now on is there's a lot of uncertainty about the PSC diagnosis, and I think it's very difficult and challenging for the clinicians. It's even more so for individuals who are having to live with PSC with that uncertainty and not knowing, how the disease is going to behave over the next 10, 15, 20 years, and that is where the risk stratification comes into play. And in terms of the natural history of PSC itself, it progresses at a very variable rate from individual to individual. But I think what is important is that not everyone will progress. And I think that is the key message. There are complications of PSC that people can get, and that include things like cholangitis, jaundice. There is a risk of malignancy. We know about that. In some patients, about 20 to 30% of people who have PSC, they will progress, unfortunately, and develop cirrhosis. And that is the progression that we want to halt by trying to find new treatment. Once people develop cirrhosis, then they are at risk of getting other complications of cirrhosis itself. And that may be in addition to the risk of PSC, but also the complications of cirrhosis, like the fluid buildup, jaundice. And that is the point where we need to start thinking about liver transplantation early in the context of PSC. So this is the timeline. So I said there's a lot of preclinical diagnosis. So these are people where the diagnosis may have not been made, or it has been diagnosed purely because of sort of abnormal liver blood tests, and patients may not necessarily be symptomatic. And then we know that over the next few years, some people may develop cholangitis, bouts of jaundice, which then lead to cirrhosis, and then eventually leading to liver transplant and other complications after that. But I think the important thing is that not everybody will go through this journey. A lot of the people may just have the diagnosis and not progress down this road. What is difficult for us as clinicians is to try and find out at the very beginning who will progress and who will not progress. And I think that is why there's a lot of active monitoring that we have to do, make sure we follow patients up, look for other complications. You may have read about or heard about the UK PSC risk score. So this is what came out of the UK PSC study as well. And this was designed to try and predict the short-term and the long-term risk. It did look at a lot of various blood test parameters to try and see if there was a model whereby we can predict. And in principle, yes, you can. You can do a UK PSC risk score calculation. But I think some of the blood tests that are used in this model, we know in PSC they fluctuate. For example, the alkaline phosphatase. We know that has a very fluctuant pattern. Sometimes it is about 200, sometimes it can go up to 600. So it does not really give us a very clear picture as to how the disease is behaving. It can be helpful in research trials, but on a day-to-day clinical practice, I don't think that is something that is very useful at the moment. And it's not something that we routinely use in clinics to inform about the prognosis and the outcome. I think what is important, I think what we have realized is that people who have PSC involving both the bile ducts in the liver and the main bile duct, which is the common bile duct I showed you on the initial picture, they have a higher risk of progression to liver cirrhosis and other complications. And I think the focus has to be on active monitoring and closer follow-up on those individuals to try and pick up any complications sooner rather than later. So I think we do know that there are some clinical features that we look at to try and sort of gauge who's likely to progress over the next few years. I think treatment is a very hot topic, is very controversial in the context of PSC, and a lot of drugs have been studied, but unfortunately none have been shown to alter the disease progression. And by disease progression I mean progressing from PSC to the point where people get cirrhosis. And I think that is the bit that we need to change, because that is what's going to change the overall outcomes. These are the various drugs that have been studied in PSC. So those that suppress the immune system, because in case it's an autoimmune component, anti-fibrotic drugs to try and reduce the degree of scarring that people get, anti-TNF, like what people use for ulcerative colitis, but unfortunately none of them have shown any impact on disease progression or the prognosis. What we do know is that the subset of people with PSC who have an autoimmune component, or if they've got the IgG4 related disease, they are the ones who will respond to steroids. And I think that is why it's important to think about those conditions early on, and if needed, the only way you can diagnose these two conditions would be probably by a liver biopsy and a specific blood test. And I think if there is a clinical suspicion there could be an element of autoimmune overlap, then your clinician or your consultant should arrange a biopsy and make that distinction, because that treatment for that would be very different and usually very responsive. I think there is a lot of debate on the role of ursodeoxycholic acid. Some of you may be on this drug, some of you probably are not. And in the last few years, there has been a meta-analysis of 8 different good high-quality trials looking at the role of ursodeoxycholic acid in PSC. What is important to remember is that these were short trials, so between 3 months to 6 years of follow-up only. And the total number of patients was relatively small. And the conclusion from this sort of meta-analysis, where they looked at all of this and how effective urso is, there was not enough evidence to support or to refute the use of ursodeoxycholic acid. There has been some studies about sort of whether ursodeoxycholic acid may have a role in preventing bowel cancer in people who have both PSC and ulcerative colitis. But again, there was some more recent data which has not shown any consistent or a protective effect of ursodeoxycholic acid. And based on these studies, these are the recommendations from national and international liver organizations. So EASL is the European Association for Study of the Liver. The data was limited. They don't really make a specific recommendation. These are quite old now. And in terms of preventing the risk of bowel cancer, there was limited evidence, and they have suggested to consider in higher risk groups. American Association for Study of Liver, they recommend against the use of urso completely, and the BSG, which is the British Society of Gastroenterology, these are the guidelines that came out last year, and they have suggested there's no role for urso for either of the two conditions. I think some of you may be taking ursodeoxycholic acid, and I think there is a lot of variation despite these guidelines. Some clinicians still use ursodeoxycholic acid, some people don't. I think what has been consistently shown is that ursodeoxycholic acid does improve liver blood tests. What it hasn't shown is that whether that improvement in liver blood tests has an impact on the disease progression or the need for transplant 10, 15, 20 years down the line. And I don't think the studies have been long enough. So there is a variation in practice. Despite these guidelines, some clinicians are still using it. Sorry.
So obviously these are quite compelling. So what is the argument for clinicians to be using or recommending ursodeoxycholic acid?
So I think in terms of, we do know that it does have an effect on liver blood tests.
Yeah.
So it does improve the liver blood tests.
So there isn't a link to those improved blood tests?
Correct.
In terms of improving the condition?
Absolutely. And the data that is based on is fairly short-term studies. And if you can imagine that the time to progression from the diagnosis of PSC on average is anything between 10 to 23 years, and I don't think there have been any studies done looking at the effect of ursodeoxycholic acid for that long. The median follow-up in the meta-analysis was only, the maximum was about 6 years. So there is still a lot of debate. I think it is down to the individual clinician, I suppose. Using high-dose ursodeoxycholic acid is probably not the right thing to do, which is about 28 to 30 milligrams per kilogram body weight. Most people who would prescribe it between 10 to 15 milligrams per kilogram, and that has shown to be safe in the context of PSC. but not necessarily associated with impact on the disease progression.
What would you say about the use of URSO in people who are post-transplant?
So I think the risk, again, purely from the PSC data alone, I don't think there is any role in the context of PSC, for recurrent PSC, after a transplant. So unless there is evidence of what we call a cholestasis, and in people sometimes they may develop some anastomotic stricturing which may cause symptoms, I think you probably could use that, but not with a view to modifying the risk of recurrent PSC after a transplant. So I don't think there's any evidence to suggest that. Yes.
I was diagnosed with PSC in 1993, early 1993 March, and I was prescribed ursodeoxycholic acid, trimethoprim, and something else that's been changed since. I take 650 milligram tablets every night with food, and that is dependent on my weight. I have to make sure my weight is exactly right, otherwise. So that's in 1993.
Yep.
I've been told that if I was diagnosed with PSC today,
Yep.
I would not be prescribed ursodeoxycholic acid. So is it the ursodeoxycholic acid that's been keeping me going? I've now had it I've now had PSC, and partway through my 27 years I've had it, I was told that I didn't have PSC at all because I'd outlived the time that I was allotted. So I was given an MRI. I was told that I didn't definitely have it. This is
Okay.
by a consultant. The MRI showed that I did actually have serious primary sclerosing cholangitis, and he said if I was diagnosing that with today, you wouldn't be taking this drug.
Yeah.
So I said, well, what do I do now then? And he said, if it ain't broke, we're not going to mend it. So is it ursodeoxycholic acid? I've had it for 27 years. I've gone past my sell-by date twice. So I would like to know which piece of that is either my body's reacting to it or the pills are doing something.
So I think that's the dilemma that people have about ursodeoxycholic acid, because when you look at the trials and the research studies, there hasn't been a link that has been established which definitively says that ursodeoxycholic acid changes the overall outcome. So on that front, it's probably just your natural disease course that has kept you going and you just haven't progressed. How much part urso has played in that, I don't think anybody can say confidently. What I tend to do is I do try and prescribe ursodeoxycholic acid for a period of 12 months. And if there is no meaningful improvement on the liver blood tests, then I think it's entirely reasonable to discontinue it because in line with the current guidelines. So I think that's the difficult bit, I think, and that's why people, have different practices. But to answer your question, I don't think anybody can say whether it was the ursodeoxycholic acid that protected you, or whether it was just the fact that you were one of those who never was going to progress in the first place. I think, and that distinction is not possible.
I wish that there had been better research on this.
Yes.
At the time, because there are patients that swear it
Yeah.
makes them feel better,
Yeah.
and it's difficult when the guidelines are saying no. Like the wording of the UK guidelines says we do not recommend it, as though it's really scary. So.
Yeah, no, I think absolutely, and I think there was only one study which had shown harmful effects of urso, and that came from the US, and that was using high dose of ursodeoxycholic acid, which is 30 milligrams per kilogram per day, which is twice the dose that we would normally prescribe in the UK. So if somebody was taking 1,000 milligrams based on their body weight as 15 milligrams per kilogram per day, that study looked at the effect of 2,000 milligrams of urso. Now, that is not prescribed in the UK. That is the only study that showed harmful effects of urso, and that is what led to these guidelines being so cautious about ursodeoxycholic acid. It was just one paper. But And I think that is why there has been so much debate. I think the only thing I didn't mention about the UK guidelines from last year is that they say don't start URSO for newly diagnosed patients, but those who are already taking it, then they can be left on it. They're not asking, oh, if you're stopping it, then they have to have the discussion with the individual, and only if they were happy to continue and monitoring the blood test closely.
I was just asking because I didn't know whether it was the ursodeoxycholic acid keeping me going.
Yeah.
I have to say I'm not complaining. I'm quite happy with that.
I would continue it. Yes. Okay.
We need to get someone to follow this chap around for a
Well, exactly. We need your blood sample.
I've already given.
I'm sure. Okay, so in terms of sort of moving on,
Could I ask one
yeah,
question?
of course.
Directly on URSO.
Yeah.
I don't know if you're going to step onto that. You know, there is the new URSO, NOR-URSO,
Yep.
right, which is, I assume, in phase 3 currently.
Correct.
Can you update us on that, please?
So I think we are still waiting for some more robust data to come out of the research trials, and I think NOR-URSO, that is being studied in the UK. So I think we're probably not going to be able to share the data at present, but I think that is something that is being studied, and we need to look at the data and see if that's going to have any significant impact. But I think with PSC, it's all about the timing as to how long can somebody be followed up for before we realise that whether it's making a big difference or not. So I think watch the space, is what I would say, but we are waiting for that data to come
They
out.
don't give us any clues to
No.
disclose, do they? And while
No.
it's still recruiting.
Okay.
Nothing.
Okay, so I've got my 5 minutes left now. So in terms of general management for the PSC, so I think Claire has already covered all of this, and I think it's important that if you are taking medications for other conditions, that you mention that to your clinician, to your consultant, to your GP about having PSC, because a lot of antibiotics, analgesics, painkillers can sometimes affect. Itch is a symptom which can be quite debilitating, and there is effective treatment available. The first line treatment, if somebody has got itching, is cholestyramine. It tastes horrible, but some people find it very helpful. If that doesn't work, then you've got some options for second line treatment. And they do make a difference. So I think if you are suffering, I think make sure that you mention that to your clinician, because they can consider these medications. Fatigue, there is no licensed treatment, and I've explained on the previous slides that it's very complex, it's multifactorial, and the focus has to be on managing the overall condition and other medical issues that may be contributing to fatigue. In terms of the outpatient monitoring, so what I tend to do in a sort of clinic when I normally would see all my PSC cases at least every 6 months. The more severe ones or the more progressed ones probably more frequently. They need to have blood tests. Annual ultrasound scan is recommended, and this is not to look at the liver predominantly. Obviously, you look at the liver on the scan, but it's mainly to look for gallbladder polyps, and that is the reason why we're doing the scan, because you can't really look at the bile ducts on the scan. There is a high risk of gallbladder polyps in PSC, and normally, if somebody's got a new polyp, the recommendation would be to have the gallbladder taken out, depending on how big it is, but that's why we're doing the scan. The MRI scan, it's variable. But normally, if somebody has got PSC affecting the bigger bile ducts, the main bile ducts, we would be doing an annual scan to look for any progression, to look for any signs of any malignancy or cancer in the narrowed bit of the bile duct. It's important to screen for osteopenia, osteoporosis, vitamin D deficiency. About 15% of PSC individuals may have it. And those who have coexisting bowel disease, annual colonoscopy is very important. We're trying to set up a joint PSC IBD clinic, because people who have both these conditions, they go to gastroenterology for their bowel follow-up and then come to too many hospital appointments. And I think it makes sense that we see these individuals in one clinic. And I think it's important we realize that it's not practical for people to just keep coming for different blood tests, for different appointments. So we are going to try and do that. And I think most centers should try and have a joint clinic set up. In terms of research, so I've just got a slide just outlining the current trials that are going on, not just in the UK, but across. But I think I wanted to bring your attention to there's a lot of interest in modulating the gut microbiome. And my first slide, I showed how closely the gut is linked to the liver. And I think there is some evidence that modifying the gut bacteria, so making the good, sort of increasing the proportion of healthy bacteria in the gut, may have a positive impact on the liver disease as well. So these are some of the antibiotics that are being studied. Rifaximin was not found to have any significant improvement, but the data for vancomycin and some of the other antibiotics is still outstanding. There's also a phase 1, phase 2 trial looking at fecal transplantation, which has taken quite a lot of interest, both in bowel disease as well as liver disease, as well as PSC. I just really wanted to mention about the Wales PSC. So we are in Cardiff. There is a national UK PSC audit looking at how people are being followed up in different hospitals, what monitoring they're having, are they having the surveillance scans regularly, and with the purpose of sort of trying to minimize the variation. So in terms of, so we will try and collect this data, and you can probably get more information via the PSC support group if you're interested. So finally, I just want to thank all of you for coming today, but also for taking part in the UK PSC study. If you haven't, then you can get in touch. I'm sure there's information on the UK PSC website and the PSC support website, how you can. All the investigators who've done the research and the PSC Support UK, of course, and our collaborators in Norway for my work as a research fellow. Thank you. Happy to take any questions.